This talk is on post-operative care, recognition and management of complications. Following a caesarean section, the patient should have an anaesthetic follow-up. We need to ensure that they fully recovered from their spinal and don't have any adverse effects. So we need to check that the patient's got their mobility back, that they are walking normally without weakness the day after their surgery. We need to check that their bladder function and control is back to normal. So I would ask, have you passed urine following removal of the catheter and did it feel normal? We need to ensure that they've got sensation back, so I'd ask if there's any numbness anywhere that they've noticed. In addition to these neurological signs, we should also ask about headache and pain control. It is very common for women who've had a baby to have a headache due to dehydration or lack of sleep, but we need to inquire about the nature of the headache and ensure that there isn't a more serious cause. A post-dural puncture headache may not occur the day after the spinal or epidural. It may take 2 days to 2 weeks to appear, and therefore we should counsel the patient when to return if they have got a bad headache. It's also important to check about pain control, that if they've had a caesarean section, they're likely to have pain post-operatively, and it's important that that pain is adequately controlled so that they can look after their baby. I visited a patient for an anaesthesia follow-up who had been to the bathroom and passed urine, and the midwives were happy to discharge her from hospital, and the patient herself was going to leave. I asked her, was she walking normally? And she said no, and I observed her walking and discovered that she had a neurological injury. She had a weakness in her leg, that she was unable to move her foot properly. And if we hadn't done this routine screening, she would have left hospital at risk of falling over while carrying her baby, because she had a neurological injury that she was unaware of. So it is very important that we screen for these things. So I'm going to just talk a bit about a postpartum headache. So like I said, a headache is very common, but we need to rule out serious causes. So there are a few very serious causes of headache that may occur in a woman postpartum. Pregnant women and in the postpartum period are more at risk of a venous thrombosis, so that can present as a severe headache. So we need to keep that in mind. Infections such as meningitis or malaria, and a post-dural puncture headache. So they're quite serious causes we need to really rule out. And how are we going to rule out serious causes? We need to take a history from the patient. We need to ask about the onset of the headache, the nature of the headache, what makes it better, what makes it worse, if there's any history of fever, vomiting, blurred vision, dizziness, ringing in the ears. We should examine the patient, so we should check for any signs of meningism, make sure that we check temperature, check heart rate, look for any signs of sepsis, and then we do a neurological examination looking for any neurological deficit. We could perform some investigations, so a simple full blood count and CRP can be useful in ruling out infection. Obviously the patient's likely to have a rise in inflammatory markers following a caesarean, but a trend in these markers will be helpful if the patient doesn't get better. If we are very, very concerned, it might be important to do imaging of the brain, particularly if we're concerned about a venous thrombosis. So post-dural puncture headache. This can occur any time in 2 weeks after the woman has had an epidural or a spinal. The risk of getting a dural puncture is massively increased by using a bigger needle. So if you are performing a spinal, use absolutely the smallest spinal needle that you can find. And if you rotate the needle so that the bevel is parallel with the spine, so it's not pointing up, it's pointing to the side, that will also reduce the risk of post-dural puncture headache. If the patient does come with a headache, how do we tell if it's a post-dural puncture headache? These patients will often complain of ringing in the ears. They will say that the headache is improved by lying down, worse on standing up. They may have associated nausea, they may complain of blurred vision, and they may have a cranial nerve palsy, a unilateral cranial nerve palsy on examination. The good news is that most of these headaches will resolve within a week, and we can encourage the patient to do the things that will help, which are lying down, which the patient will naturally do anyway, ensuring adequate hydration, that the patient is losing CSF and that's why they're getting the headache. So by drinking plenty, they'll ensure that they can make adequate CSF. Simple analgesia, paracetamol, ibuprofen, if there's no contraindications, will be very helpful. Some patients may need stronger analgesia such as codeine if available, and caffeine. So I'd encourage the patient to have some coffee if they can tolerate it. If the patient's headache doesn't get better, you should ask them to come back and see you. The definitive treatment for a post-dural puncture headache is an epidural blood patch. So an epidural blood patch is the injection of blood into the epidural space, and this blood is the patient's own blood, and it is thought to seal the hole in the dura and prevent the CSF leak. So this would be performed if conservative management fails. Obviously you need a member of staff who's very experienced in performing epidurals, because one of the risks of performing an epidural is causing a dural puncture. So if there's nobody available who's confident and competent with epidurals, then this treatment's not going to be available. Ideally 2 staff should be available. The most experienced clinician in performing epidurals performs the epidural. That's not necessarily the most experienced clinician. The hospital director might never have performed an epidural. It needs to be the anaesthetist who's performed the most epidurals. They will perform the epidural, and then the second member of staff, who will also be performing the procedure with strict asepsis, will do the venipuncture or put in a cannula and take out the patient's blood. So I say strict asepsis. This is key, that you need to have proper surgical scrub, sterile gown, sterile gloves. You'll have your hat and mask on, and then you need to draw up all of your equipment in a sterile way. And the same goes for the member of staff taking the blood from the patient's own arm. You take 25 to 30 ml of the patient's own blood and inject that into the epidural space once you've reached the epidural space. So stop when the patient complains of fullness or discomfort in their buttocks or their back or their neck, and they will often say that the headache or the tinnitus has immediately resolved. And then you remove the epidural needle. So it is quite a large volume of blood. Encourage the patient to lie flat for 1 to 2 hours after the procedure. That if they lie flat for this amount of time, they're more likely to have success with the epidural blood patch. And then they can go home that day, but you should encourage them to avoid stretching or lifting for 24 hours. And then you need to safety net that you've now injected something into the epidural space, and obviously you've taken every precaution possible to prevent infection, but blood is a nutrient-rich medium and it is an infection risk. So if they start getting worsening back pain or fever, they need to come back to the hospital right away. So you need to let them know that. So I'm just going to talk about neurological complications. So there are obstetric nerve injuries and anaesthetic nerve injuries. And the patient that I described at the start of this talk, it turned out that she had a unilateral weakness that was affecting her ability to lift her foot. And because it was unilateral and it was peripheral, it was much more likely to be obstetric than anaesthetic, and it was due to the pressure of the baby's head at the pelvic brim. And you can see in this picture here, the link for this picture is at the end, that there are many nerves that come over the pelvic brim that are at risk during labour, even in normal labour and delivery, and obviously if there are any complications or if forceps are used or if there's a caesarean section, then they're more likely to be at risk. And indeed the positioning of the patient on the bed, if we use stirrups, that's going to put pressure on peripheral nerves also. Obstetric nerve injuries are less likely to be associated with pain. They're usually unilateral, they are usually peripheral, and the good news is that most will get better within 6 months. So if you have established that this is indeed the problem, then you can arrange for them to have some physiotherapy, and you can reassure them that most will get better within 6 months. Anesthetic neurological complications. We've talked about post-dural puncture headache, but putting a needle anywhere near the nerve roots or the spinal cord can cause trauma. So that's why we go below the level of the spinal cord. We go below L1, which is where the spinal cord terminates in most adults, and try and go to L4-5 or L3-4. But there are nerve roots and nerves coming off there, so there is risk of direct injury from poking a needle there. There's also risk of bleeding, so this is why we don't perform a spinal or an epidural in a patient who's got very low platelets or deranged clotting, because they can get a clot there that can then compress the spinal cord or nerve roots. So you can see in this diagram, there's the red thing represents a blood clot, a posterior subdural abscess or epidural abscess or hematoma, and that will cause pressure on the spinal cord or the nerve roots coming off it. Those patients will complain of pain as well as weakness. So they will have severe back pain, they may have severe nerve root pain, so they might complain of a sciatic pain in a nerve root distribution, and they may indeed have weakness in that nerve root distribution. And obviously if it's a large hematoma, it may affect multiple nerve roots. An epidural abscess is similar to that in presentation, but the patient will also have signs of sepsis, so they will be potentially tachycardic, febrile, and may be very unwell. An arachnoiditis can be caused by infection or inflammation affecting the arachnoid layer. This is caused by a spinal, and this is why we avoid the use of preservatives in the injections that we give into our spinals, and this is why we make sure everything is drawn up in a very aseptic way. Indeed, the chlorhexidine solution that is sometimes used to clean the back prior to the injection, high concentrations of that can cause arachnoiditis, which can cause weakness as well. And meningitis, that we have injected something into the CSF, and if that is not done in a fully aseptic way, or even with full asepsis, there is a risk of introducing infection. So patients may present with headache, fevers, neck stiffness, photophobia features that are consistent with meningitis. Hard to differentiate sometimes from the post-dural puncture headache, but the meningitis is an infection, and the patients may have more signs of infection. The epidural hematoma and the epidural abscess are neurosurgical emergencies. So if you suspect these in patients, it is really important that you refer them to a neurosurgical center so that they can have appropriate imaging. The ideal imaging is an MRI, and neurosurgery if necessary. So if a patient has got worsening back pain, that's not getting better, it's getting worse, and they're getting weakness, and they may have a fever in the case of an epidural abscess or signs of sepsis, it is very important that they get referred. Thankfully, these complications are rare, but it's very important that we don't miss them. So, just to reiterate, the red flag signs: back pain associated with weakness or fever, bladder or bowel disturbance, so a cauda equina syndrome, because the nerve roots to the bladder or bowel are affected. If the symptoms are getting worse, not better, or if there's a severe headache associated with a fever or neurological deficit. These are the red flag signs, and we must take them very seriously. We need to refer for urgent neurosurgical decompression in the case of an epidural hematoma or epidural abscess.